Welcome to Pediatric Case Review, Musculoskeletal Series. Today we cover slipped upper femoral epiphysis, also known as slipped upper femoral epiphysis. This is one of the most important hip conditions affecting adolescents, and a high-yield topic for pediatric board examinations. We will walk through 14 carefully crafted clinical cases covering pathophysiology, epidemiology, clinical presentation, physical examination signs, imaging, classification, treatment strategies, complications, and special scenarios including endocrine workup. Let us begin. Case 1. A 12-year-old obese boy presents with 3 weeks of left groin and medial thigh pain, a mild limp, and limited internal rotation of the left hip. No trauma is reported. What is the primary mechanism responsible for slipped upper femoral epiphysis? Option A. Acute traumatic fracture through the physis. Option B. Posterior and inferior displacement of the femoral head relative to the neck due to physial weakness. Option C. Avascular necrosis of the femoral head. Option D. Inflammatory destruction of the growth plate. The correct answer is option B. Posterior and inferior displacement of the femoral head through a weakened physis. In slipped upper femoral epiphysis, the femoral head remains seated in the acetabulum while the femoral neck displaces anterosuperiorly. This occurs because the physial zone of hypertrophy weakens under hormonal and mechanical stresses. Obesity dramatically increases shear stress across the physis. The injury pattern is analogous to a Salter-Harris type 1 physial fracture, where the slip occurs through the hypertrophic zone of the growth plate rather than through bone or by inflammation. Case 2. A pediatric endocrinologist refers a 10-year-old boy with hypothyroidism for a hip evaluation after he reports a 4-week history of right hip pain and difficulty walking. Which of the following is the strongest independent risk factor for slipped upper femoral epiphysis? Option A. Male sex and age 11 to 14 years. Option B. Family history of hip dysplasia. Option C. Obesity, defined as body mass index above the 95th percentile. Option D. Endocrine disorder regardless of weight. The correct answer is option C. Obesity with body mass index above the 95th percentile. Approximately 50 to 70% of all slipped upper femoral epiphysis patients are obese. The male to female ratio is 2.4 to 1, with peak age in boys being 12 to 14 years and in girls 10 to 12 years. An important concept is the distinction between typical and atypical slipped upper femoral epiphysis. Typical cases occur in obese peripubertal children with no endocrine cause. Atypical cases, such as in this boy with hypothyroidism, present at younger or older ages with low body mass index, and always require a full endocrine workup. Bilateral involvement occurs in 20 to 40% of cases. Case 3. A 13-year-old girl with a body mass index at the 97th percentile presents with a 5-week history of left knee pain. Her mother reports a slight limp. On examination, the knee appears entirely normal. What is the most likely explanation for her knee pain? Option A. Patellofemoral syndrome. Option B. Medial collateral ligament injury. Option C. Juvenile idiopathic arthritis. Option D. Referred pain from slipped upper femoral epiphysis of the ipsilateral hip. The correct answer is option D. Referred pain from ipsilateral slipped upper femoral epiphysis, which is a classic and frequently tested presentation. The obturator nerve supplies both the hip and the medial thigh and knee, so hip pathology commonly refers pain distally. Up to 25% of slipped upper femoral epiphysis patients present with isolated knee pain and a normal-appearing knee. The critical clinical rule is this: always examine the hip in any child presenting with unexplained knee pain. Failure to do so is the most common cause of delayed diagnosis of slipped upper femoral epiphysis. Other symptoms include groin pain, limp, and pain that worsens with activity. Case 4. A 12-year-old obese boy presents with right hip pain and antalgic gait for 2 weeks. On examination of his right hip, there is limited internal rotation and flexion. When you passively flex the hip, a specific sign is noted. Which clinical sign is most characteristic of slipped upper femoral epiphysis on physical examination? Option A. Obligate external rotation with hip flexion, known as the Drayman sign. Option B. Trendelenburg sign. Option C. Thomas test positivity. Option D. Flexion, abduction, and external rotation test positivity. The correct answer is option A, the Drayman sign, which is pathognomonic for slipped upper femoral epiphysis. When the hip is passively flexed beyond 90 degrees, it spontaneously and obligately externally rotates. This occurs because the posteriorly displaced femoral head causes mechanical impingement that forces the limb outward during flexion. At rest, the affected limb appears shortened and externally rotated. Internal rotation is characteristically reduced, often measuring less than 0 degrees. Antalgic gait and Trendelenburg gait may also be present but are not specific. The Draymond sign is the examination finding that should immediately raise your suspicion for this diagnosis. Case 5. A 13-year-old obese boy has a 3-week history of right hip pain and limp. An anteroposterior pelvis X-ray is taken, and you are looking for a specific radiographic sign to confirm slipped upper femoral epiphysis. Which radiographic sign on anteroposterior pelvis X-ray is most sensitive for detecting early slipped upper femoral epiphysis? Option A, Shenton line disruption. Option B, widening of the acetabular teardrop. Option C, Klein's line not intersecting the lateral femoral head, known as the Trethowan sign. Option D, periosteal reaction along the femoral neck. The correct answer is option C, the Trethowan sign, also known as Klein's line sign. Klein's line is drawn along the superior border of the femoral neck on the anteroposterior view. Normally, this line intersects at least 20% of the lateral femoral head. In slipped upper femoral epiphysis, the femoral head is displaced inferiorly and posteriorly, so Klein's line passes entirely above the epiphysis without intersecting it. The combination of anteroposterior and frog leg lateral X-rays provides the highest sensitivity together. The frog leg lateral is particularly useful for detecting subtle posterior slips. Additional findings to look for include physial widening and the metaphyseal Blanche sign, also called the Steele sign. Case 6. A 14-year-old boy presents to the emergency department with sudden severe right hip pain that started after a minor fall. He cannot bear weight at all. On anteroposterior pelvis X-ray, the right femoral epiphysis is severely displaced, measuring more than 50% of neck width. The left hip appears normal. According to the Loader classification, how is this slipped upper femoral epiphysis classified? Option A, stable slipped upper femoral epiphysis, low risk of avascular necrosis. Option B, chronic on acute slipped upper femoral epiphysis. Option C, pre-slip stage. Option D, unstable slipped upper femoral epiphysis, high risk of avascular necrosis up to 50%. The correct answer is option D, unstable slipped upper femoral epiphysis. The Loader classification is based on the ability to bear weight. Stable slipped upper femoral epiphysis means the patient can weight bear with or without pain and carries an avascular necrosis risk of less than 10%. It accounts for 90% of cases. Unstable slipped upper femoral epiphysis means the patient cannot weight bear at all and carries an avascular necrosis risk of approximately 47%. It requires urgent surgical stabilization. The Southwick slip angle, measured on the frog leg lateral view, grades severity as mild below 30 degrees, moderate between 30 and 50 degrees, and severe above 50 degrees. Case 7. A 12-year-old boy with confirmed slipped upper femoral epiphysis has a frog leg lateral X-ray taken. You need to quantify the severity of the slip to guide management. Which angle is used on frog leg lateral X-ray to grade the severity of slipped upper femoral epiphysis slip? Option A, Southwick slip angle. Option B, Hilgen-Rainer epiphyseal angle. Option C, Viborg center edge angle. Option D, sharp acetabular angle. The correct answer is option A, the Southwick slip angle. This angle is measured on the frog leg lateral X-ray and represents the angle between a line perpendicular to the femoral epiphysis and the femoral shaft axis. A normal hip has a Southwick angle of approximately 10 degrees. Mild slipped upper femoral epiphysis is defined as a slip angle below 30 degrees. Moderate is between 30 and 50 degrees. Severe is greater than 50 degrees. This grading directly guides the surgical approach, with severe slips requiring more complex correction and carrying higher risks of avascular necrosis and chondrolysis. The Viborg and sharp angles are used in hip dysplasia assessment, not slipped upper femoral epiphysis grading. Case 8. An 11-year-old boy with a body mass index at the 98th percentile is diagnosed with a stable, mild slipped upper femoral epiphysis of the right hip with a Southwick angle of 22 degrees. He is weight-bearing with a limp. What is the first-line treatment for a stable, mild slipped upper femoral epiphysis? Option A, spica cast immobilization for 6 weeks. Option B, surgical hip dislocation with epiphyseal reduction. Option C, in situ single screw percutaneous fixation. Option D, traction followed by closed reduction. The correct answer is option C, in situ percutaneous single screw fixation, which is the gold standard treatment for all stable, slipped upper femoral epiphysis regardless of severity grade. A single cannulated screw is placed centrally and perpendicular to the physis in the femoral epiphysis. The goals are to prevent further slipping and to achieve physical closure. Critically, Forceful reduction is never attempted, as this dramatically increases the risk of avascular necrosis by disrupting the retinacular blood supply. Postoperatively, the patient begins partial weight-bearing and advances to full weight-bearing as tolerated. Prophylactic contralateral fixation remains debated but should be considered in patients with endocrine disease or those who are very young, due to the higher risk of developing a contralateral slip. Case 9. A 13-year-old boy is diagnosed with an unstable severe slipped upper femoral epiphysis. He is brought to the operating room urgently. The attending surgeon is discussing whether to attempt reduction. Regarding reduction in unstable slipped upper femoral epiphysis, which statement is most accurate? Option A. Forceful closed reduction is recommended immediately. Option B. Gentle positioning reduction may be attempted, but forceful reduction is contraindicated. Option C. Reduction is never attempted in any type of slipped upper femoral epiphysis. Option D. Open reduction with internal fixation should always be performed first. The correct answer is option B. Gentle positioning may be attempted, but forceful reduction is absolutely contraindicated. In unstable slipped upper femoral epiphysis, the surgical protocol involves urgent transfer to the operating room, gentle positioning of the limb on a fracture table, and then screw fixation either in situ or after gentle positioning reduction. The avascular necrosis rate in unstable slipped upper femoral epiphysis reaches up to 47%. Forceful manipulation further compromises the already tenuous blood supply to the femoral head and must never be done. Femoral head decompression by capsulotomy may reduce avascular necrosis risk in some cases, though this remains debated. Close follow-up with magnetic resonance imaging at 3 to 6 months is essential to detect early avascular necrosis. Case 10. A 13-year-old boy underwent urgent screw fixation for an unstable, slipped upper femoral epiphysis 4 months ago. He now presents with worsening hip pain, difficulty walking, and a new limp. Anteroposterior pelvis X-ray shows sclerosis and flattening of the right femoral head. What is the most likely diagnosis? Option A. Chondrolysis. Option B. Implant failure with re-slip. Option C. Septic arthritis of the hip. Option D. Avascular necrosis of the femoral head. The correct answer is option D. Avascular necrosis of the femoral head, which is the most feared complication of slipped upper femoral epiphysis. Sclerosis and collapse or flattening of the femoral head on X-ray are late signs. Magnetic resonance imaging detects avascular necrosis much earlier. Other important complications include chondrolysis, defined as joint space narrowing below 3 mm or loss of more than 50% of cartilage, which causes painful stiffness and is associated with screw penetration. Femoroacetabular impingement is a late sequelae presenting as groin pain in young adults from residual cam deformity. Leg length discrepancy can develop in chronic severe slipped upper femoral epiphysis cases. Case 11. A 12-year-old girl, 8 months after in situ screw fixation for stable slipped upper femoral epiphysis, presents with progressive hip stiffness and pain. X-ray shows a joint space of 2.5 mm, while normal is greater than 4 mm. There are no signs of avascular necrosis. Which factor is most associated with chondrolysis after slipped upper femoral epiphysis? Option A. Screw penetration into the joint space. Option B. Use of a single cannulated screw. Option C. African American race. Option D. Delay in diagnosis greater than 4 weeks. The correct answer is option A. Screw penetration into the joint space, which is the primary iatrogenic cause of chondrolysis. Chondrolysis is defined as loss of articular cartilage with joint space below 3 mm or loss of more than 50%. It is also associated with African descent, female sex, severe slip, and prolonged spica cast use. Clinically, the patient presents with a painful stiff hip and limited range of motion in all planes. Treatment includes nonsteroidal anti-inflammatory drugs, physiotherapy, and joint distraction for severe cases. Prevention is key. Intraoperative fluoroscopy must confirm screw position to ensure the tip does not penetrate the joint surface. This is why careful screw placement and regular post-operative imaging are essential. Case 12. A 9-year-old boy with a body mass index at the 45th percentile, meaning he is not obese, is diagnosed with left-sided slipped upper femoral epiphysis. His growth chart shows significant growth deceleration over the past 2 years. The right hip X-ray appears normal. What is the most appropriate next step in management? Option A. Prophylactic fixation of the right hip only. Option B. Repeat X-ray in 6 months. Option C. Endocrine workup including thyroid function, growth hormone axis, and gonadotropins. Option D. magnetic resonance imaging of both hips to assess cartilage. The correct answer is option C, endocrine workup, because this is an atypical presentation requiring investigation. The rule is clear. Any child with slipped upper femoral epiphysis who is younger than 10 years or is non-obese must be evaluated for an underlying endocrine disorder. The workup includes thyroid-stimulating hormone and free thyroxine for hypothyroidism, insulin-like growth factor 1 and growth hormone stimulation for growth hormone deficiency, luteinizing hormone, follicle-stimulating hormone, and testosterone for hypogonadism, and cortisol for Cushing syndrome. These hormonal disorders weaken the physis through altered maturation. Endocrine slipped upper femoral epiphysis also carries a higher bilaterality risk, so prophylactic contralateral fixation should be strongly considered in these patients. Case 13. A 17-year-old male presents to an orthopedic clinic with a 2-year history of activity-related right groin pain, plicking, and reduced internal rotation. He was treated for slipped upper femoral epiphysis with in situ fixation at age 13. The screw has since been removed. X-ray now shows cam-type deformity of the femoral head-neck junction. What late complication has developed? Option A, recurrent slipped upper femoral epiphysis. Option B, cam-type femoral acetabular impingement. Option C, hip dysplasia. Option D, leg calf Purdas disease. The correct answer is option B, cam-type femoral acetabular impingement, which is a common late sequela of slipped upper femoral epiphysis, especially after moderate to severe slips. Residual posterior displacement of the femoral head creates a cam lesion at the head-neck junction. During flexion and internal rotation, this cam lesion impinges against the acetabular labrum, causing labral tears and, over time, early-onset osteoarthritis. Clinically, the patient presents with activity-related anterior groin pain and a positive flexion, adduction, and internal rotation test. Internal rotation is markedly reduced. Treatment options include hip arthroscopy for mild to moderate cases or surgical hip dislocation with osteoplasty for more severe cam deformities. Case 14. A 10-year-old girl with a body mass index at the 96th percentile of African American background is diagnosed with right-sided stable mild slipped upper femoral epiphysis and undergoes successful in situ fixation. The contralateral left hip X-ray is taken and appears normal. Regarding the contralateral hip, what is most appropriate? Option A, no further imaging needed if currently asymptomatic. Option B, prophylactic fixation is always mandatory in all patients. Option C, immediate magnetic resonance imaging of the contralateral hip to rule out pre-slip. Option D, watchful waiting with scheduled clinical and radiographic follow-up, with consideration of prophylactic fixation in high-risk patients. We want to take a moment to tell you about the Pediatric Case Review community on Patreon. If you find these lectures helpful, our Patreon community takes your learning to the next level. All videos are organized by system in one place, so you can access every lecture on musculoskeletal, respiratory, rheumatology, neonatal, and other topics without searching through individual posts. All presentations used in the videos are also available as photos, so you can read through the slides, review the cases, and practice all multiple-choice questions at your own pace. For details on how to subscribe, simply comment below in this post, and we will message you directly with all the information. And that brings us to the end of this lecture on slipped upper femoral epiphysis. Let us recap the key takeaways. The classic patient is an obese peripubertal male. Always examine the hip in a child with unexplained knee pain, as referred pain is a classic trap. The Draymond sign, which is obligate external rotation with hip flexion, is pathognomonic. First-line imaging is anteroposterior pelvis plus frog leg lateral X-ray, and the Trethowan sign on Klein's line confirms the diagnosis. Gold standard treatment is in situ screw fixation. Never attempt forceful reduction. Avascular necrosis is the most feared complication, especially in unstable cases. Atypical age or weight always triggers an endocrine workup. If you found this lecture valuable, please follow Pediatric Case Review for more case-based lectures, and drop any questions or thoughts in the comments below. We read them all.